Bueno, vamos a empezar la siguiente mesa. Tengo el placer aquí de ver a dos grandes amigos, Dominique y Kenneth, y a Seth, que debe estar llegando en algún momento. Entonces, esta mesa o este panel es sobre medicina social y salud global en tiempos de COVID. Bueno, por decir algo así, una pequeña introducción, ¿no? La pandemia de COVID representa un desafío sin precedentes de gobernanza de salud pública global que ha puesto en jaque sus presupuestos teóricos y ha trastocado dicotomías y jerarquías de la salud global como global, local, el norte global frente al sur global, políticas de arriba hacia abajo frente a intervenciones de base que estructuran el campo de la salud global. Las medidas promovidas por la OMS y otros organismos sanitarios internacionales no son viables en muchos países que, como hemos visto, han provocado crisis económicas sin precedentes, aumento de las desigualdades raciales, de género y económicas, así como enfermedades crónicas, abuso doméstico, violencia de género, etc. Por lo tanto, la atención a los diferentes contextos locales es fundamental. Al exacerbar las disparidades existentes en salud, esas medidas violan dos principios básicos de la salud global, que sería la importancia del contexto y el carácter primordial de la justicia social y de la equidad. Con relación a la actual pandemia, lo que el COVID ha puesto de manifiesto es que el papel central de especialistas del norte global y su influencia en la OMS está siendo desplazado por el liderazgo efectivo de varios países asiáticos y africanos en políticas eficaces de contención del virus. Podemos, por lo tanto, decir que lo global está sufriendo un proceso de desoccidentalización, como Dominique Behague, que está aquí, y yo hemos escrito en algún lugar, y al mismo tiempo surgen relaciones de interdependencia entre diferentes locales que conllevan una necesidad de colaboración no solo internacional, sino también nacional y regional, lo que exige reformular nuestra comprensión de lo local. Si los presupuestos básicos de la salud global se han trastocado y aquellas medidas verticales que no tomen en cuenta los contextos, ni identifiquen ni den soporte a las poblaciones vulnerables no son efectivas para el control de la pandemia, ¿no sería el momento de reinventar la salud global? Como dicen en un texto Sridham Samsundar y sus colaboradores, uno de los autores es Seth Holmes, que está precisamente aquí en la mesa, que dirían que precisamente la pandemia ha puesto de manifiesto el vacío de la retórica de equidad en salud global, la debilidad de una agenda de salud global impulsada por la seguridad de la salud, que asigna una cantidad desproporcionada de recursos y atención en salud a centros de poder a expensas de poblaciones más vulnerables a nivel global, y los impactos negativos para la salud de los diferenciales de poder, no solo a nivel mundial, sino también regional y localmente. Entonces, hemos visto como en muchos contextos, en todos prácticamente, la inequidad es la fuerza motriz de la pandemia y su enfrentamiento requiere cooperación global, solidaridad y coordinación. Reimaginar la salud global para los autores exigiría que las organizaciones de salud global adoptasen estructuras de gobernanza con representación en las poblaciones más marginalizadas y vulnerables, etc. Y en un artículo que escribimos Dominique, yo y otros autores, precisamente hablamos de la idea de, previo a la pandemia, reimaginar la salud global a través de la medicina social, que es uno de los temas que tenemos hoy para discutir. Y en ese artículo proponíamos conceptualizar lo social a partir de 5 ámbitos que eran reconfiguraciones del Estado, nuevas formas de activismo político, el filantrocapitalismo y la economización de la vida, la economía de la atención y los desafíos del cambio climático antropogénico y finalmente la geopolítica entre norte y sur globales. Entonces sería un poco esa idea de descolonizar la salud global, repensar la salud global, que han aparecido cada vez más artículos durante la pandemia y muchos apoyan en las tradiciones de la medicina social. En ese sentido, cito a la profesora Myung-Soo Khan de la London School of Hygiene and Tropical Medicine, con eso acabo, que dice: existe el mito de que las soluciones de los países de ingresos altos son mejores, lo que nos ha llevado a pasar por alto a los países que han operado con éxito redes comunitarias más informales. Y concluye: pero hemos visto cuán perjudicial es asumir que las soluciones siempre se originan en Occidente. Entonces yo creo que esa es una introducción al tema de hoy y tengo un placer muy grande de tener aquí a mi lado a mis 3 colegas, amigos, Dominique Behague, que es profesora titular del Departamento de Medicine, Health and Society y de la Facultad de Antropología, y del Departamento y del Centro de Estudios Latinoamericanos en la Universidad de Vanderbilt y también profesora titular en Salud Global y Antropología del Departamento de Salud Global y Social Medicine de Medicina Social del King's College de Londres. Kenneth Camargo, que es catedrático en mi institución previa, el Departamento de Planeamiento y Políticas de Salud en el Instituto de Medicina Social de la Universidad Estadual de Río de Janeiro, y Seth Holmes, que es Martin Sisters Endowed Chair, profesor titular de Antropología Médica y de Salud Pública en la Universidad de California, Berkeley, y también es cofundador del Centro de Berkeley de Medicina Social. Entonces, es un placer tener aquí a mis colegas y podemos seguir la orden de las presentaciones. Primero Dominique, después Kenneth y finalmente Seth, si os parece bien.
Sí. Bueno, muchas gracias por la invitación. Estoy entusiasmadísima de estar aquí con colegas y amigos. El trabajo que voy a presentar es uno que hemos hecho con Francisco y que está, la verdad es que al comienzo, así que estamos con ganas de ver qué tipo de reacción y comentarios tienen. Y tengo que pedir disculpas que voy a leer mi paper en inglés para asegurarme que lo que quiero decir sale correcto. Bueno, much has been written about Bolsonaro's neglect, incompetence, and opposition to science during the pandemic. His government has consistently undermined and derided public health directives endorsed by the WHO and state and municipal health secretaries in Brazil. Leading journalists have written front-page stories showing how Bolsonaro has consistently countered public health mandates by promoting large non-masked public gatherings and political rallies, avoiding mask wearing himself, comparing the coronavirus to a little flu, and telling Brazilians to stop whining as deaths spiked. The dire consequences of his failed governance are all the more evident when we consider that, unlike many countries in the global south, or the so-called global south, Brazil has a well-structured unified health system, the SUS, created in 1989, with nearly universal access to health care. The development and expansion of the SUS has been praised by the World Health Organization for offering lessons on how to scale universal health coverage in a highly unequal country and with relatively lower resource allocation to healthcare compared to that found in middle and high-income countries. Despite considerable gains in access and coverage of essential services with demonstrable impact on health indicators throughout the 1990s and 2000s, more than 30 years after its implementation, SUS suffers from persistent geographical inequities and insufficient funding, in part because of the growing privatization of health. The Bolsonaro government has then taken advantage of the pandemic to further weaken the SUS through the privatization of administrative roles and management, the erasure of social participation, and the relaxation of worker protection laws. The government has, in other words, capitalized on this public health emergency to intensify its policies of dispossession, which have had a particularly harmful effect on marginalized communities. Against the backdrop of Bolsonaro's headline-worthy negligence, mutual aid and solidarity actions have also hit the headlines. Even before the death toll began to rise, residents in the informal settlements of the Periferia began organizing to protect themselves against both the novel coronavirus and the government's neglect. Seasoned activists fundraised, mobilized donations, distributed food, masks, hygiene kits, wrote policies and manifestos. Volunteers signed up to learn basic first aid and walk door to door checking on neighbors, while others drove the streets using megaphones to deliver public health messages. Local journalists relied on social media to counter fake news and fight for the accurate documentation of COVID deaths, and residents converted closed schools into isolation wards. In a feat of skilled management and social mobilization, one community in the periferia of São Paulo, Paraisópolis, was able to keep transmission and mortality rates lower than the average for the city in the first months of the pandemic. Several international media outlets reporting on these actions have noted the solidarity and resilience and altruism even of residents, sometimes linking these qualities to the pressures of living in conditions of scarcity. So what we argue in some of our first publications and want to say today is that the partiality of this narrative needs to be confronted head on. There is far more to this picture, a more that is vital to broader discussions of civil engagement, public policy, governance, and democratization. So mutual aid, as we all know, is a form of localized collective care that has swelled in many countries during the pandemic, also at other key moments in history. Notable, well-known example is in the US during the abolitionist movement of the 19th century, and then again civil rights in the 60s. While mutual aid is organized around the logistic aspects of care, it is also a form of political action that challenges paternalistic and charity-oriented governance models, working to deactivate structures of inequity while building new infrastructures for living. So the work presented here today is part of an ongoing project supported by the Spanish BBVA Foundation, grant for the project New Solidarity Networks in COVID-19, Emotional Communities Activism and Mutual Aid, which involves fieldwork in Spain and Brazil, and Francisco and I are working more intensely on the Brazilian component. The project is based on participatory research with academics, activists, artists, teachers, students, and in addition to collaborative interviews, also a collaborative production of a film organized and directed by those in mutual aid groups and initiatives. In the face of grossly ineffective responses to the pandemic in Brazil, we suggest that grassroots work in the periferia has much to teach government, public health, and the global health community. Based on then initial published reports and also the insights of those we've interviewed, we argue that solidarity practices challenge 4 key assumptions in conventional public health. And we'd like to thank some of our interlocutors here who were happy to be named. The first assumption relates to the dominance of vertical or targeted interventions in global health, based on the premise that scarce resources should be spent on a few high impact and so-called feasible interventions to be delivered by community actors with minimal training. These logics have been at work in COVID as well, with public health specialists arguing against a one-size-fits-all approach and calling instead for, quote, realistic alternatives focused on, quote, doable measures. Activists' work defy this view of public health action. They're engaged in a form of collective governance that works synergistically towards both short, targeted, and broader interventions that build infrastructure and tackle multiple determinants of health, from economic livelihood, food scarcity, to mental health and police repression. Also, activists do not aim to centralize their networks into a specialized umbrella, emphasizing instead the importance of reciprocity between smaller and more localized networks. This facilitates flexibility and quick responsiveness, and it depends on a willingness and ability to train in new skills while working in multiple domains. Second, assumption we'd like to challenge. In public health, targeted vertical interventions tend to compete for one another for funding and prioritization, which often contributes to the fragmentation of pre-existing health systems. What is noteworthy among community activists is that the creation of a highly responsive and pliable network, intricate mechanisms of redistribution of resources, coupled with meaningful relationships built over time and widespread informed critique about the political and economic structures that cause harm. In other words, discourses of resource scarcity are not front and center in activists' work. The infrastructures mobilized to contain COVID have long been in the making. Another important point, particularly during previous crises, such as in the aftermath of major floods, during peaks of police brutality, and with the leading organizational role that sex workers played, for example, during the HIV/AIDS epidemic. Between each of these crises, one finds the steady building of systems needed to counter what the grassroots reporting organization Rio on Watch has called necropolitics, drawing directly from Cameroonian philosopher Mbembe's work, which underscores the state's power to selectively remove the right to life. These pre-existing infrastructures have been built not just with minimal help, sometimes from the state, but often in spite of the state's actions, and often with the help of other grassroots collective, as well as key individuals in local government and major organizations such as the Fiocruz, which is Brazil's main public health institution. So despite high levels of precarity, activists' commitment to building these local expertise and infrastructural systems means that surplus can be shared. In Rocinha, for example, activists helped doctors at a local clinic demand and create a system to ensure that COVID deaths be accurately registered. When doctors in the Mare, for example, ran out of masks, they received donations not from government, but from local organizers. A key aspect of this infrastructure building is the creation of local data collection systems, something community actors are rarely entrusted with in public health programs. Tainá Madeiros of the Coletivo Papo Reto, a citizens collective, told us how vital their transparent information system has been for keeping track of donations, informing logistic decisions, countering infodemic of fake news. In the Complexo de Alemão, activists have been using data collection of their own to highlight the government's consistent underreporting of COVID deaths. When underpinned by principles of fairness and democratic governance, such data collection is vital to self-determination. So to state that residents are creating infrastructures rather than systems, networks, organizations, is to draw explicitly from social scientists' recent interest in studying new forms of politics that can arise when people do more than struggle to secure their rights from the state. Building and maintaining infrastructures takes expertise, time, labor, nimble problem-solving flexibility. This is quite distinct from the issue-specific hyper-specialization that typifies the way many governments and even NGOs develop policies. We could go further to argue that making infrastructures is a form of critical pedagogy, for it reveals the fault lines in governance structures while also providing new methods for organizing and living life differently. So this leads us to the third assumption. Over the past 2 decades, global health has turned increasingly towards evidence-based practice, an allegedly politically neutral and objective way of developing and evaluating policy. And we know from the literature the development of evidence-based policy has led to the sidelining of politics, contributed to the rise of technocratic approaches, and again, the prioritization of vertical actions over horizontal structural ones. In contrast, activists are maintaining both vertical and horizontal actions in large part because of their commitment to keeping histories of discrimination and oppression in full view. For example, their use of the hashtag #GovernaFavelas underscores how the pandemic has not simply triggered a health and economic crisis, but it has exposed longstanding racial, economic, and health injustices. Here on Watch, again, to quote them, has described in their materials how the pandemic has further accelerated the state of exception in favelas, a politics of death implemented by the states. So the way mutual aid envisages and works for change is more in line with the field of social medicine, or collective health as it's known in Brazil, but in all of Latin American social medicine, where activists, physicians, and public health experts have worked synergistically with a wide range of groups engaged in political transformation. Social medicine has long challenged mechanistic and politically neutral understandings of the so-called social and economic determinants of health by shedding light on upstream political determinants to those. So this includes unregulated capitalist production, political corruption, concentration of power. For example, literature from collective health will critique pro-poor health policies such as microcredit schemes. While these might have a temporary impact on health, they do little to affect structural change and are often used in ways that actually relieve governments of their responsibility. So mutual aid shares in this vision. The activists we interviewed underscored the fundamentally political nature of their work, a fact that has obviously become doubly important given President Bolsonaro's dismantling of the SUS. Fighting for governmental and institutional reform, some explained, is vital but can only go so far. Like much humanitarian and philanthro-capitalist action, government reforms can entrench structures of inequity that demobilize political action and often end up serving the economic interests of the elite. So the slogan, "Solidarity, not charity," approaches inspire activists to dismantle these systems by building new democratic alliances that reject hyper-individualism and hierarchical leadership. So here's our fourth and final assumption for today, at least. Public health and global health often struggle to truly recognize the significance of so-called community participation. The call for community action is typically based on the assumption that policies are developed and rolled out by government, and that the community then participates in implementing those policies. Yet the pandemic has highlighted how grassroots infrastructures and collective care are indispensable and have been indispensable to the efforts that public universities, local and regional governments in Brazil, the Fiocruz, have had in mitigating the central government's disastrous approach. This is perhaps an untold aspect of the success story of SUS, perhaps less known outside of Brazil, in the decades before the pandemic. The regionalized and decentralized structure of SUS means that municipal and state governments have historically had relative autonomy to define policies and structures of care. What remains of this local infrastructure has been vital during the pandemic. It has enabled public health officials to bypass federal policies altogether, and in part because of the tradition of collective health in Brazil, many doctors and public health specialists see themselves also as activists. They do not shy away from the politics of health, from engaging in building political coalitions. As one example, in the first year of the pandemic, a number of governors who openly opposed Bolsonaro's policies were the ones to implement earlier, more robust and effective measures. But what we want to argue is that in this complex landscape, we contend that even local governance successes owe more to the infrastructures created by favela activists than is often acknowledged. So to wrap up, we're currently witnessing the mainstreaming of mutual aid in specific localities across the globe. We've seen similar risings in Mumbai, Los Angeles, Madrid, Sao Paulo, Nairobi. And those communities are starting to share expertise and resources. Accounts such as these should in no way be used to relieve governments, institutions, individuals in positions of power of their own responsibilities, and that's certainly a risk. The risk that solidarity language and achievement can be used to justify the further privatization of healthcare and neoliberal policy reforms that line the pockets of big business. This is a very real risk and by no means new. As research on the primary healthcare movement of the 1970s shows, public health collaborations with the so-called community have tended to be used to justify targeted interventions only, feeding into what Vincent Navarro has described as policy without politics. Perhaps the starkness of the multiple intertwined crises of the pandemic will help reframe community-based work, not as a complement to public health or as implementers of health policy, but as core producers of knowledge, management expertise, and civic-minded organizing. So thank you. And I am done.
Thank you, Dominique.
Eu peço desculpas, eu vou falar em português, fui assim orientado por Francisco, espero que seja possível compreender. Caso contrário, posso falar em inglês se alguém quiser, enfim. Eu queria agradecer o convite e a oportunidade de estar aqui, como o Francisco já havia colocado anteriormente, com colegas, não apenas amigos, mas amigos queridos. E vai haver alguma superposição de algumas coisas que eu vou falar em relação ao que Dominique havia colocado. Na verdade, eu acho que se a gente tivesse invertido a ordem, talvez até ficasse melhor, mas enfim. Eu sou, como o Francisco já havia colocado, eu sou professor do Instituto de Medicina Social da Universidade do Estado do Rio de Janeiro e queria falar um pouco do papel que foi desempenhado pela saúde coletiva já vem sendo desempenhado, acho que Dominique enfatizou bastante a resposta de coletivos auto-organizados da sociedade civil, da população em geral, e eu queria falar um pouco do papel que instituições acadêmicas vêm desempenhando nesse processo. Só que, antes de entrar nisso, Dominique chamou a atenção para o fato de que nós utilizamos no Brasil o termo saúde coletiva, e eu acho que seria importante recuar um pouco historicamente para ter um entendimento de onde isso veio, né? A medicina social brasileira tem uma proximidade grande, mas tem certas especificidades em relação ao restante da América Latina, e ela começa a se desenvolver de forma muito marcada na década de 60, e foi nucleada por alguns médicos progressistas, entre eles meu infelizmente falecido professor Ézio Cordeiro, que hoje em dia dá nome ao nosso instituto, e que trazia uma perspectiva crítica muito influenciada por uma visão de esquerda, muito influenciada pelo marxismo, sobre o que poderia chamar de determinação social, determinantes sociais operando no processo de saúde e doença. Mas à medida que ela se expande e que ela se institucionaliza, ela começa a incorporar novas perspectivas teóricas, novos atores, particularmente muitos pesquisadores, muitos colegas da área de ciências sociais, e nesse momento se avalia que o nome medicina social para esse coletivo de pessoas que estavam trabalhando era inadequado. E, por outro lado, saúde pública remeteria para uma visão que também não era condizente, né? Uma visão mais clássica que também não era condizente com essa perspectiva crítica que estava sendo desenhada. Então, foi criado o nome saúde coletiva e ele começa a ser institucionalizado já na década de 70. Foi muito importante a criação do Centro de Estudos Brasileiros, Centro Brasileiro de Estudos em Saúde, o SEBS, em 1976, e, finalmente, a ABRASCO, a Associação Brasileira de Saúde Coletiva, que é a nossa organização e que teve um papel, vem tendo, historicamente, um papel muito importante nesse processo de institucionalização da saúde coletiva. E o que nós entendemos, né, por saúde coletiva, pegando uma ideia da Karen Gnoscetina, seria uma arena transdisciplinar que inclui diversas perspectivas teóricas sobre a saúde de populações, mas também ação política, como o Dominique havia colocado. E, desse ponto de vista, ela se estrutura de forma bastante intensa a partir já da década de 60, no movimento de reação e resposta a uma ditadura militar que se instaurou no Brasil em 1964, e que a luta por melhores condições de saúde foi um pouco uma ponta de lança dessa luta pela redemocratização, e que se articulou muito em torno do chamado movimento da reforma sanitária, que era uma tentativa de redefinir o modelo de prevenção e atenção à saúde, que era completamente desarticulado no Brasil até então, e que vai ser criado o SUS, como a Dominique chamou a atenção, que tem um ponto muito importante na criação de uma nova, após o final do regime militar em 1985, uma nova Constituição é votada e ela inclui a ideia de que o direito à saúde é um direito do cidadão. E isso foi uma base para essa articulação técnica e política do SUS, que vai se consolidar um pouco mais com a Lei Orgânica da Saúde, que vem em 1990. Como já foi colocado anteriormente, há uma série de problemas, sobretudo da ordem do financiamento. Desde a sua criação, né, no final da década de 80 e início da década de 90, o SUS jamais contou com um financiamento adequado, necessário para seu funcionamento pleno. Apesar disso, se desenvolveu uma série de frentes. Primeiro, um Plano Nacional de Imunização é um dos maiores planos de vacinação que eu conheço no mundo inteiro, e isso teve um papel estratégico muito importante, como a gente vai ver a seguir, que vacina gratuitamente uma série de vacinas, né, que foram sendo implementadas para toda a população, desde crianças até idosos. Desde a década de 90, houve também um processo de expansão da cobertura, da atenção, que também vai ter uma importância muito grande, como a gente vai ver daqui a pouco, através da chamada saúde, do Programa de Saúde da Família, mais tarde Estratégia de Saúde da Família, que trabalha com a ideia de equipes, com médicos, enfermeiros e trabalhadores da comunidade, né, agentes comunitários de saúde, que são responsáveis por um determinado território. É uma política de adscrição de população a uma determinada equipe, com uma grande capilarização por quase todo o território nacional. E uma coisa que foi muito importante na infraestrutura política do SUS, que foi a criação de órgãos colegiados que tem uma importância muito grande na determinação da própria política de saúde e no seu acompanhamento. Em particular, o Conselho Nacional de Saúde é uma espécie de grande parlamento da saúde, com representação de trabalhadores, usuários e das instâncias governamentais, e as articulações também dos secretários estaduais e municipais de saúde, CONAS e CONASEMP. Bom, a Covid no Brasil, como a Domingos já tinha colocado, teve uma resposta bastante prejudicada pelo próprio governo federal, né? E aqui a gente vê a progressão de casos que foi crescendo ao longo de 2020 e teve um pique recente esse ano. E mais impressionante é a curva de mortalidade, né? Especialmente se a gente considera a disponibilidade de vacinas que já existiam praticamente desde o final de 2020 e que foram implementadas tardiamente no Brasil e que foram responsáveis por esse pico de mortalidade em torno de março e maio do ano passado. E que levam um cumulativo, eu vi recentemente, no dia 9 de maio, de 664.139 óbitos, levando-se em consideração o que o Dominique havia falado, que há, sim, ainda, possivelmente, muita subnotificação dessas mortes, né? O que dá uma proporção de casos de 316 óbitos por 100 mil habitantes, que, entre os países com grande população, é um dos maiores no mundo. E aí começam os problemas, né? Quer dizer, no primeiro momento, houve uma total recusa do governo federal em adotar qualquer tipo de medida não farmacológica de controle. E um trabalho feito por colegas, e aí já começo a falar da importância da ação acadêmica da saúde coletiva. Vários pesquisadores, inclusive colegas da minha própria instituição, fizeram um trabalho junto com o Oxfam e tiveram uma estimativa que desses óbitos, só em 2020, 120 mil poderiam ter sido evitados com a adoção de medidas de distanciamento social, que não só não foram adotadas, como o Dominique havia mencionado anteriormente, se estimulou o contrário, aglomeração, desprezo pelo uso de máscaras, etc. E também a resistência à implantação de qualquer tipo de ação econômica, que penaliza, evidentemente, a população mais pobre, que não tem como adotar medidas de distanciamento. E aqui, o que o Dominique colocou em relação à retirada de direitos trabalhistas é muito importante. A falta de proteção social e o crescimento da chamada gig economy, né, de entregadores, pessoas que operam a partir de aplicativos, criou uma massa de trabalhadores sem qualquer tipo de proteção social, sem qualquer direito e sem nenhuma capacidade de se proteger das consequências, né, de poder se isolar de alguma forma, reduzir os contatos. Foi instituída a contragosto, quer dizer, isso foi uma luta política bastante forte, de um subsídio mensal que permitiu a sobrevivência de algumas pessoas à medida que houve uma brutal recessão da economia, fechamento de vários negócios, sobretudo no setor de serviços. E nenhuma coordenação central. O SUS, apesar da sua descentralização, ele reconhece ao governo federal o papel de coordenação das atividades, e que simplesmente não foi exercido de forma adequada e pelo contrário, né, foram estimuladas uma série de ações contrárias ao que seria recomendado, em particular essa insanidade da recomendação do uso da cloroquina, mesmo quando já havia evidência acumulada de que não surtiria qualquer efeito e poderia, ao contrário, criar problemas adicionais de saúde. E, num segundo momento, né, no momento que vacinas já começam a se tornar disponíveis, houve um atraso no início da vacinação, ela só começa já tarde, em janeiro de 1961, e as mensagens do governo federal foram completamente ambíguas, né, falando que as pessoas iriam ter problema, que as vacinas não tinham sido suficientemente testadas. Quer dizer, ao invés de estimular que a população buscasse essa medida de proteção que se mostrou efetiva, ela trabalhou no sentido contrário e patrocinou todo tipo de negacionismo, que é uma das dificuldades que se tem, né, em relação a essas mensagens que Dominique já havia mencionado, de que se tratava apenas de uma gripezinha, que não ia afetar as pessoas, e uma série de mensagens, francamente, quase eugenistas, né, quer dizer, que só quem estava em risco era a população mais idosa, que ia morrer de qualquer jeito, ou coisas desse tipo. O SUS, então, como já foi falado várias vezes, né, e aí chamar a atenção, né, a sigla é Sistema Unificado de Saúde. Por que unificado? Porque, a partir da constituição desse novo sistema, ações que eram dispersas em vários órgãos de governo, tanto do ponto de vista do governo federal, né, na sua estrutura vertical, quanto nas instâncias descentralizadas, elas teriam supostamente que agir de forma unificada. Até que ponto isso foi conseguido é ponto de discussão, mas certamente houve um avanço em relação à situação anterior. Houve uma mobilização por parte de várias secretarias estaduais de saúde para oferecer leitos de CTI, que é uma importância muito grande, centro de tratamento intensivo, que em outros países, pensar no caso dos Estados Unidos, por exemplo, uma internação numa unidade dessas leva uma pessoa à falência. No Brasil existe a cobertura por parte dos serviços públicos, ainda que não necessariamente na quantidade que seria necessária, é uma situação infinitamente melhor do que seria caso não houvesse esse sistema. Os estados também, como o Dominique colocou, se organizaram para fazer um pool de informações sobre casos e óbitos, que é fundamental para o acompanhamento da pandemia, na medida que estava havendo uma série de falhas deliberadas ou não por parte do governo central. E instituições centenárias importantes da saúde coletiva, a Fiocruz já foi mencionada, o Instituto Butantan em São Paulo, que colaboraram na avaliação e na produção de vacinas. Alguns ensaios clínicos, esses institutos foram coparticipantes com instituições de pesquisa na China e no Reino Unido, que poderiam ter dado um começo muito antecipado, né, para a vacinação no Brasil, caso não tivesse havido uma série de obstáculos colocados. E essa capilaridade do sistema assegurou a vacinação. Uma vez que houve a decisão de começar a vacinar, o número de vacinas e a vacinação da população avançou relativamente rápido, apesar de todos desses obstáculos, né? E nós temos esses dados aqui recentes, que isso veio de um órgão de imprensa, que da população total, da população vacinável, né, com 5 anos ou mais, 88%, quase 89% já tomaram pelo menos uma dose e 82 e poucos por cento tomaram já 2 doses. A dose de reforço em relação à população vacinável está, infelizmente, ainda não avançando tão rápido como nós gostaríamos. E, finalmente, a contribuição que a saúde coletiva, enquanto a instância acadêmica e política deu, né, houve uma forte denúncia e crítica da real situação epidemiológica, né, à medida que se tentava ocultar os dados sobre número de casos, número de óbitos. Houve uma articulação e alguns colegas nossos, inclusive, foram e continuam sendo vítimas de perseguição política por conta disso. Um colega de Manaus, Gessem Orellana, outro do Rio Grande do Sul, que em função das denúncias que fizeram, se tornaram alvo de campanhas de difamação. Também o Pedro Elal, né, lá de Pelotas. Uma série de alertas que foram feitos e que orientaram a ação dos estados que optaram, que se articularam em função disso. Houve uma iniciativa muito interessante de vários estados do Nordeste brasileiro de formação de um consórcio para o enfrentamento da pandemia e a produção de várias simulações de modelagem de quais seriam as consequências da pandemia, caso medidas fossem tomadas ou não, tiveram uma importância muito grande na opinião pública, né, de criar condições, ou pelo menos de se contrapor à verdadeira campanha de desinformação que vinha sendo feita pelo governo federal. Né? E esse enfrentamento da desinformação, várias pesquisas vêm sendo feitas, a Abraço tomou a iniciativa de fazer várias mesas, vários eventos online de divulgação, e atuando junto a esses órgãos colegiados, né, o CONASEM, o CONABS e o Conselho Nacional de Saúde, mostrando mais uma vez essa atuação técnico-política da saúde coletiva brasileira. Bom, isso é o que eu tinha preparado para apresentar num primeiro momento e estou aberto a questões e para discussão posteriormente. Agradeço a vocês e devolvo a palavra à Débora.
Okay. So thank you, Francisco Ortega and the Medical Anthropology Research Center for inviting us. It's an honor to be on a panel with you and with Dominique Behague and Kenneth Camargo, both of whose work I have been following for some time. I will be speaking in English. I'm happy to answer questions in Spanish. I can understand some Portuguese, but not well enough to speak it. So I'll be talking a little bit about some collaborative work in a few different places related to politics, space, and racialization during COVID-19. Some of this was part of an article that I believe Francisco mentioned, looking at 3 different global cities in the United States, and one is related to one rural county in the United States. In general, what we've seen thinking together through politics, racialization, and space is that COVID-19 has intensified the lethality, the deadliness of social and political inequities, that there are high levels of COVID-19 infection and death that stem from exposure to racialized exclusion, segregation of neighborhoods, and labor exploitation in interlocking systems of capitalism, racism, and xenophobia or nationalism. We're thinking partially with Juan de Lara, who writes about the re-territorialization of race, in which the spatial embeddedness of race or racialization is a political technology in urban landscapes and reproduced as differential proximity to transportation, jobs, services, and pollutants. And we're also thinking with Melamed, who writes that capital can only accumulate by producing and moving through relations of severe inequality, and racism enshrines the inequalities that capitalism requires. The first case that we think through in the book, in this article, was based largely on ethnographic work and observant participation by a physician anthropologist named Ariola Oni Orison. And in San Francisco, what we saw was a very early response to COVID that was centrally organized, the first city in the United States to declare a state of emergency and to engage in mask protocols, social distancing protocols, and stay-at-home measures early on. And early on, there were 0 cases in the city, even at the time when it was declaring a state of emergency preventatively. The 5 counties in the San Francisco Bay Area were the first to mandate the shelter-in-place stay-at-home order in March that was then followed by other counties and cities in the United States. And yet, within San Francisco, we also have a history of policies and practices moving from forced evictions and redlining, and I'm happy to talk a little bit more about that later, to segregated public housing and gentrification that's concentrated San Francisco's dwindling Black population into the southeastern corner of the city, which is called District 10. In this district, we also have intensified environmental contamination, the city's landfills, the city's heavy industry, the city's power plants, much of the highway traffic, and the city's Superfund sites. Superfund sites are those that are declared by the federal government so toxic that they receive special funding from the federal government to clean them up. At the same time, in San Francisco, we see that there are 30 different COVID testing sites. There are only 3 in District 10. The majority of them are in other neighborhoods. And of those 3 in District 10, 1 is only open to patients from that clinic. 1 is only open 2 days a week. And 1 is in a public health center that has not had a good relationship with the neighborhood due to histories of racialized interactions. The University of California, San Francisco worked with the city of San Francisco to conduct testing as part of a research project. And they specifically proposed conducting testing within District 10. But some of the community members responded with statements like, we don't need the coronavirus map to tell us the problems that we have in the community, because it's the same map that shows diabetes. It's the same map that shows unemployment. It's the same map that shows disconnection to the rest of the city because of poor transit. It's all the same information. In other words, every map that they've ever seen and every study they've been a part of has shown that they're less connected with the rest of the city. They have worse jobs, they are more poor, and they have what in the United States is often referred to as health disparities. Another community member stated, I'm here to do this project, however it turns out, but I'm not going to stop telling you what you're doing is setting something up to serve the institutions, and the institutions do not serve or protect us. We've been thinking about San Francisco as a site of racialized difference, in which the primary mode through which District 10 community members are invited to join the rest of the city is only through participation in a research study. We also worked through ethnographic cases in Los Angeles, in this case led by physician and anthropologist Liza Buchbinder and medical anthropologist Carlos Martinez. In Los Angeles, we see decades of structural violence and marginalization of immigrant and refugee communities, as well as geographic discrimination in terms of access to public transit and access to jobs, access to health centers and hospitals. Los Angeles is 39% Latinx people, but 55% of the COVID cases and 46% of the deaths were among Latinx communities. And among young adults, 39 to 45, Latinx men and women made up 75% of the deaths in this largely working age category. The neighborhood of East Los Angeles was the epicenter of the COVID crisis in 2020. East Los Angeles is 96.7% Latinx and one of the most densely housed areas in the country. It's also considered the birthplace of the Chicano movement, the Latinx rights movement in the US. And other hotspots in Los Angeles were all predominantly Latinx neighborhoods. What we analyze in relation to Latinx communities is that, especially in this age range, many people were considered and called essential workers by the Trump administration, yet were treated as expendable. This has been analyzed by many people now. These communities were required to work, yet were not provided with protective equipment or space for social distancing. One example is the San Pedro Bay Port Complex in one area of Los Angeles. That's the warehouse capital of the country, where there are more container ships per day than any other complex in the world. Amazon, the largest employer in this region, had 20,000 frontline Amazon and Whole Foods Market employees who tested positive or presumed positive between March and September. All of these people, these workers, were confronted with this dilemma of either I preserve my livelihood to be able to pay my rent because there's no unemployment or other safety systems, or I prevent possible infection by staying home, quarantining, or isolating. The political background for Los Angeles is that most workers are not members of unions. Many are undocumented in the United States, and most, for these reasons, cannot afford to quarantine at home and are not eligible for state-sponsored pandemic assistance. In a similar time frame, former President Trump had proposed a public charge rule that would have allowed immigration officials to deny visas to persons who might need any form of public assistance or had any public assistance, including healthcare. But this proposed rule was blocked by courts. However, a lot of research that we and others have done has shown reluctance to seek care due to fear of detention, deportation, or this public charge rule, even though it was not passed. The same historic legacies and political and economic processes that have made Southern California a significant site of incredible wealth accumulation in many industries have also led to these magnified structural vulnerabilities experienced by the region's racialized and immigrant communities. The third site we think through the nexus of politics, space, and racialization is Detroit. This piece ethnographically was led by the physician and anthropologist Nadia Gaber. In Detroit, we've seen a history of Black political leadership and pro-worker and labor union organizing. At the same time, we've seen suburban sprawl that has taken away many of the good jobs, the good housing, and the taxes leading to the city's dissolution of public services. In 2013, the city itself declared bankruptcy. At that time, in response, there was strong anti-labor union austerity. The suburbs are now 95% white, and the city of Detroit is 80% black. The city water and sewer that supports 130 small cities, most of them in the suburbs, is only paid 17% by those suburbs and primarily by the poor center city. And when word of COVID-19 arrived in Detroit, the packs of water that were in grocery stores were sold out across the city, and churches, food banks, and other groups that provide water to those who need it were no longer given donations from corporate suppliers and weren't able to purchase water in bulk. In 2020, more than 10,000 households in Detroit had no water at all in their apartments and in their houses. They didn't have water for laundry, drinking, or hand washing, which is one of the primary messages regarding COVID. And one of the residents in Detroit said, when your water is shut off and you're given the director to shelter in place, we're not using the word correctly. Shelter is defined as having a place of safety and comfort and protection. And when you don't have water, that's not shelter. It's not shelter when children have to take their waste outside and throw it in the garbage. It's not shelter when you don't have water in your home and the sanitation is not available, because the city has declared that laundromats are non-essential providers, so laundromats are closed up. During COVID, the governor of Michigan, the state in which Detroit is located, declared a moratorium, a stop to all water shutoffs, because the water company had been shutting off water to anyone who could not pay their bills. Many advocates demanded that the moratorium on water shutoffs become permanent, which has not been the case. COVID and other health disparities at the same time were continuing to be attributed to genetics or behavior differences, such as the people in Detroit aren't good at hand washing, they're not good at social distancing, placing the blame on the community residents. And there was an inability of residents to access the specific water points that were set up. This political geography of racism is a pre-existing and ongoing condition that scholars and policymakers need to confront in order to interrupt the devastation being wrought by this virus that's moving along these political and social lines, many of which are racialized. The last example I'll talk about is Immokalee, Florida. Immokalee, Florida is famous for being a place with primarily indigenous Central American, especially Guatemalan, and Haitian migrant farm workers. Most of the migrant farm workers live 12 to 20 people in a trailer of this size, most of which have 1 or 2 bedrooms, so there are multiple people per room. And the people go to work on buses like this in order to pick strawberries and pick oranges. These pictures were taken during the pandemic. As you can see, there are no masks being given to anyone, and most people don't have masks on. The county that runs the public health department for the region includes the coastal towns, which are relatively wealthy and largely white, including Naples and Fort Myers, Marco Island. Also includes the internal area of Immokalee, which, as I mentioned, is primarily migrant farm workers who come from Haiti and indigenous groups from Central America. We saw several racialized and geographic differences during COVID. The wealthy white areas had large testing centers that were open every day a week in the cities along the coast. In Immokalee, there were 0 testing sites set up until, for weeks and weeks and weeks, the coalition of Immokalee workers pushed the county to have testing in that region. It was actually the second time in the history of the Doctors Without Borders that they came into the United States of America to work. And Doctors Without Borders were the primary people conducting COVID testing, while the county's testing was all being done along the coast. In the internal area of Immokalee, there was no contact tracing being done by the county, whereas there was contact tracing being done in other areas. And the county rented hotels in the wealthier, whiter areas close to the coast, so that if people needed to isolate or quarantine, they would have a hotel room to go to. But there was no space that was rented for people who lived in the more crowded housing and had less money in the internal part of the county. Later, after several weeks of advocacy, the Coalition of Immokalee Workers, the County Health Department, and other community organizations did successfully rent one area for isolation. One aspect that's important to mention is, in the midst of all these inequities in testing, in resources for isolation, community organizations, importantly, the Coalition of Immokalee Workers, were conducting advocacy and community education in multiple languages, in Spanish and English, in Haitian Creole, and in indigenous languages from Latin America. On the left, you can see some of their advocacy that was made public in blog posts and social media, pushing the governor and the county to provide what was needed for the health of farm workers in the interior part of the county. You can also see on the right that several different organizations were involved in translating information about COVID into multiple indigenous languages. The Coalition of Immokalee Workers received masks from people across the country, many of whom sewed masks themselves, and they handed out these masks for free to workers. And because many of the health systems in the United States are very place-based, in which one person signs up with one clinic and one primary care provider, the Coalition of Immokalee Workers, Doctors Without Borders, and Partners in Health worked with the organization called Migrant Clinicians Network that provides case management for migrants who are moving seasonally to different regions in order to work picking fruit and vegetables, so that case manager can forward test results, can forward charts to a new clinic, and can let each patient know when they move to a new region where the clinics are, where they can get care, because most migrant farm workers don't have health insurance. So in conclusion, thinking through all these different sites in this collaborative thought process, we've been focused on the ways in which COVID-19 inequities, both in infection and in death and in the resources related, are enacted through racialization of space. There are relatively thin forms of inclusion within biomedicine and public health, such as testing through research projects that don't work to end structural inequities, racialized labor exploitation, segregation, and geographic disinvestment. We argue that it's important to redress, to undo, to confront structural violence through socio-political change, including universal health care, workplace protections, equitable possibilities for rentals and homeownership, voting protections, many of these things that community groups, such as the Coalition of Immokalee Workers and others, have been engaged in. And we argue that it's important to confront the social determination of health in this pandemic in order to realize an adequate response to this and future epidemics and pandemics in the US and globally. And thinking a little bit with Dominique Behague and Kenneth Camargo, the framework of collective health is a very helpful framework for thinking about the political and power social context and history that leads to the health inequities we see and work against. Thank you.
Thank you, Seth.